And the main issue with COVID in the States is how variable the infection is across the geography of our country. For example, and I'm sure that New York State and in particular New York City have had a very challenging time with this, whereas Nashville, Tennessee, where I am now, for example, has not had such a measurable experience or impact. So the challenge for government leadership is that the variability in the presence of and the consequences of the virus is quite high. With that in mind, it follows that the governments that are driving the response are mostly state and local governments, because that's the level at which the variability can be managed. The brief answer is we don't know. Uh, we're learning as we go. The practice here, again, is evolving, but the current status is for patients that do not have a critical need for chemo. For example, folks that may be on maintenance therapy, sometimes we delay their visits or their treatments. However, patients that are on or beginning treatment, which is for curative intent, um, are the subset that we focus on the most. And the list of that would include, but there are others, uh, leukemia patients, patients on the transplant service, patients on cytotoxic chemotherapy, that get neutropenic, patients on combined modality therapy, such as chemoradiation. These are the subgroups that we have identified that are at a higher risk for treatment interacting with COVID. Uh, the trouble is we don't know exactly what that risk is, how to quantify it, but more importantly, how we might alter our treatments uh, based on that. Uh, Looking ahead, the plan here is for those patients that we've considered to be high risk or identified as high risk, we're going to start doing COVID screening uh, and try to guide our therapy based on whether or not a patient tests positive. So that's the current plan, but I'm sure it will morph over time as we implement it and learn more about it. In two categories, one would be the inpatient setting, so patients that have been admitted to a service, and I'm on this consulting service right now. uh, we and the hospital leadership have made it clear that we will provide full service consultations just as if we would do in the pre-COVID environment. As far as the outpatient arena, where new patients come in as usual because cancer does not stop, we also provide in-person consultations as always. Sometimes, if the patient prefers and if it's considered feasible, we will do telehealth uh, visits, but those are mostly not for new patients, but for patients in follow-up. Some of my colleagues have converted nearly all of their visits to telehealth, but certainly anyone who's getting infusional treatment will come in face-to-face. I'll provide my approach, and then I would also encourage your viewers to seek information from our our larger groups. For example, the American Society of Clinical Oncology, or ASCO.org, has very specific guidance for patients and what they can do during this outbreak regarding how things are practiced in our real world. There is nothing different in the recommendations for our patients from what the recommendations are in general from public health officials and government leadership. Hand washing, 6 feet of social distancing, and masks. And then, of course, if a patient has symptoms which could be consistent with COVID, we certainly would have them get tested. The approach in my clinic has been to delay treatment until 14 days after the infection was documented. But we understand that in some patients it can't be delayed, so these decisions would also be on a case-by-case basis. I guess, for example, if a patient, I think this would be unusual, but if a patient showed up with acute leukemia and tested positive for COVID, I think you're going to have to treat them for their leukemia. The other scenario is the possibility that patients are carrying the virus, which are and they're asymptomatic, in which case the treatment will proceed, but you may see some consequences of that down the road. And then finally, the question of immunotherapy comes to the forefront. I don't think anybody knows, I certainly don't know, what is the impact or interaction between immunotherapy and this virus. The challenge, I think, is that immunotherapy isn't a predictable immunosuppressant such as chemo, which would cause neutropenia and lymphopenia. So for the time being, we would practice a better safe than sorry approach. And if a patient is to begin immunotherapy and they are positive, we would just delay the initiation for, I guess, 14 days. For patients who are already on immunotherapy, maintenance or being treated with curative intent, we're not really sure. What we have learned is that we're adaptable as oncologists, but also, I would argue, as a population. And as far as the adaptations that we've implemented, that number one, patients like, but number two, I think are successful, is telemedicine. There's a real positive feedback from our patient population for when we're able to do telemedicine. And in particular, our catchment area geographically is quite broad, so patients may be able to avoid a long trip in for a quick follow-up visit.